Good morning, everyone. Welcome to this SKD talk series on breast cancer as we celebrate Breast Cancer Awareness Month. We're absolutely delighted to have Dr. Azlina Firzah Abdul Aziz, a renowned breast surgeon in Malaysia and internationally. And she's given us 2 hours of her time this morning. So before we start though, can I please ask all participants to turn off their video and audio throughout the whole session. If you have any questions, could you please post them through the chat and we will ask Dr. Azlina on it. For the doctors who are here, CME points will be flashed up towards the end of the session. There will be a barcode scan for you. And again, if you could really just keep your audio off throughout the whole session so that we can hear the speaker well. So, Dr. Azlina, as I mentioned, is a renowned breast surgeon. And Azlina started in her path after her master's in 2001 in surgery. She went immediately into breast surgery in 2002, the program for breast surgery in 2002. However, throughout her, prior to this, in her training, she was also in pediatric surgery, as well as in plastics. And I think as we chatted before this, that's where she said she honed her skills and has made her such a great breast surgeon. So Dr. Azlina completed her specialty training in breast and endocrine surgery in Kuala Lumpur Hospital and Putrajaya Hospital. And she was posted to Selangor Hospital in 2005, and then subsequently joined Pantai Hospital in 2008. So she is currently one of the resident consultant breast surgeons in the Breast Cancer Center in Pantai Hospital in Bangsar. She is also in numerous boards and a major champion of breast cancer awareness. So she's a council member of the College of Surgeons of Malaysia. She's the vice chair of the Women's Chapter in the College of Surgeons Malaysia. She's a member of the Breast Chapter as well in the Academy of Medicine. She's a life member of the Malaysian Oncological Society and, of course, the Malaysian Medical Association, and she's also a board member of the National Cancer Society of Malaysia. She is a proponent for breast awareness and health literacy. She champions it and has been championing it for as long as I've known her, actually, which is, you know, close on to 20 years. And so we are, as I said, absolutely delighted and honored to have Dr. Azlina here with us. So without further ado, I am going to hand it over to Dr. Azlina. Azlina.
Thank you so much, Saunthari. It is a great pleasure to be invited by National Cancer Society to spend some time with all of you to go through what is plaguing us in Malaysia with regards to breast cancer and what we need to pay attention to for the sake of our women and men in Malaysia and what we can look forward to. And with that, I shall begin.
While Dr. Azlina is putting up her slides, I'm going to tell you that Dr. Azlina has actually set a couple of questions within her slide deck itself. So when we come to the questions that Dr. Azlina has set, could you please all put in your answers or your thoughts into the chat so that it can be quite a robust discussion at that time. Well, thank you.
Okay, so here we go. All right. So the topic that was given to me today is early breast cancer. Treat, then what? So what we need to do is, okay. Now we know that breast cancer is the most important cancer in the world. including in Malaysia. So regardless of gender, breast cancer contributed to almost 20% of all new cancers in Malaysia from 2012 and 2016. This is the latest data compared to the statistics between 2007 to 2011. Hence, so what we know is the 5 common cancers among women is breast, colon, cervical, ovarian, and lung cancer. So this I obtained from the Malay Mail. In 2016, what was mentioned that greatly affects us is the economic impact of cancer. Now, due to the cost, now breast cancer, because it's the most investigated cancer, so much research and medication has been discovered for it. These are the reasons why a lot of our patients do get into economic trouble. They have used up their personal savings, they can't pay for medication, they've stopped treatment on their own. So it is quite catastrophic. Now, looking at our burden of treatment, let's look at the National Specialist Register. For our population in Malaysia, which is around 32 to 33 million people, we have, at the latest, I took this on 19th of October, we have 120 clinical oncologists on the NSR, 11 medical oncologists, 2 radiation oncologists. Now, clinical oncologists are those who are trained in medical and radiation treatment for cancer. We have 800 over almost 900 general surgeons, a lot more are in training in master's programs, and we have 59 breast surgeons on the NSR. Majority are women. Now, this was mentioned in Malay Mail on 5th December 2016. Just looking at historically, has anything changed? There's lack of cancer services in East Malaysia and the East Coast of Peninsula. Patients have to travel miles from Kuantan or from Kuala Terengganu to KL or Kota Baru to seek oncological treatment. In January 2020, still the same tune. There is lack of communications and collaboration between doctors of various disciplines and hospitals on managing patients in terms of oncology treatment. So we know in Malaysia, there is no breast surgeon on the NSR in Pahang, no oncologists. There are visiting oncologists who go to Kuantan. There is no oncologists in Terengganu. There are breast surgeons in Kota Baru. There is oncology treatment, but I'm not sure whether it's visiting from KL or not. Maybe some of you would know. So there's still lack of accessibility. So access to treatment in terms of cancer. Those in Kedah and Perlis do go to Penang for oncology and breast surgical treatment. Globally, in 2020, there were 2.3 million women diagnosed with breast cancer and 685,000 deaths. So at the end of 2020, there were 7.8 million women living with breast cancer, making it the world's most prevalent cancer. So imagine the loss of disability adjusted life years by women to breast cancer globally than any other type of cancer. And we know that younger and younger women are being discovered in their prime years to have breast cancer. So the mortality changed very little in the 1930s to the 1970s. Then in the 80s, we started to have early detection programs. And in some countries, they had free mammography screening for women from the age of 50 onwards. Now, breast cancer is not transmissible or infectious. This is something we need to emphasize to patients and their relatives, because off and on, you do find families that isolate their breast cancer relatives in their rooms with their own bathroom facilities, and there's lack of contact. We're treating them like lepers. So we need to emphasize that. Or whenever we talk about breast cancer, please tell them it's not infectious, you can touch them, etc. Okay, so I found this to be quite interesting. Professor Jayant, who is the one who started looking at intraoperative radiotherapy way back in the late 90s. So what he mentioned in this article of his in the Lancet in July 2007, breast cancer is an emotive cancer. It is a disease that affects a visible sexual organ and is the commonest single cause of death of women between 40 to 60 years of age. If we understand this, then we can understand why women come late for treatment, especially more so in Malaysia. So there is this painting that's now in the Louvre, where it portrays Bathsheba bathing by Rembrandt. So what an Italian surgeon in the modern years suspected that Rembrandt might have depicted breast cancer in his painting, as seen here in the left breast. Maybe it's not so clear because it's greatly magnified. So this is Rembrandt's model and mistress, Henrika Stoffels. So this was way back in the 1600s. Later on in the years, Carol Bonicelli, to the artist who painted Venus Revisited, her eyes serene but touched by sadness, reflect awareness of a wound, but her beauty is unmarred. We are, after all, more than the sum of our parts. I repeat this to our patients. Look, yes, you have breast cancer, but let's look at other aspects of your life. You are not just your boobs. So we need to give them the encouragement to move on whenever we have already somewhat stabilized their condition. So we have found that approximately half of breast cancers develop in women who have no identifiable breast cancer risk factor. You know, when we clinically assess them in the clinic, we go through the risk factors thoroughly, and most of the times we find that the only risk factor is being a woman and above 40. And I've had many patients like this, just that suspicion that they are above 40. Lesion doesn't look so malignant, but however, I send them for biopsy and lo and behold, it is an early cancer. So we look at the non-modifiable risk factors. So being a woman, increasing age, the younger they are at the first period, the menarche, the higher the risk. The age of the natural menopause, the later it is, higher the risk, because if it's early menarche and late menopause, the longer span of years exposed to the hormones that may implicate the risk of breast cancer. If they've had breast cancer before, of course, this is something they can't modify. Family history, unfortunately, you can't choose your relatives, and ethnicities. In Malaysia, we find that Chinese women has the highest risk of breast cancer. We don't know why. So, of course, when we need to do studies like that, it takes years and years and years. These are the modifiable risk factors where breastfeeding reduces the risk of breast cancer. It does not cut it down to zero risk. Women must be advised to please exercise for physical activity, because we do find that obesity increases risk of breast cancer, especially more so after menopause. Alcohol is confirmed to increase the risk of breast cancer. There was a study way back in the 90s in the UK where it was mentioned that even a glass of wine a day does not reduce your risk of breast cancer. Exposure to tobacco smoke, secondary smoke, prolonged use of hormones. Therefore, women on hormone replacement therapy around menopause, those who actually need it, we need to limit the years to maybe 5 years or less. And those who have had radiation for treatment in their childhood for certain cancers, they have a higher risk of getting breast cancer in their later years. So in Malaysia, the new cases of breast cancer has increased from 32.1 to 34.1 of overall cancer among Malaysian women. So a 2% increment is a lot. So, and we have found that the incidence increases at the age of 25 and peaked at the age of 60 to 64, although we have had patients in their 80s who are discovered with breast cancer. So I believe that we have to go by your clinical assessment and not just tell women, oh, you can stop having your screening mammograms at 65, as mentioned in the guidelines of the CPG. We have to assess each patient by their individual risk. So I mentioned this before, the highest is found in Chinese women. And clinically, some signs of probable cancer, immobility of the mass, some thickening, skin changes, some nipple discharge, blood stain or otherwise, any discharge that comes out from the nipples need to be investigated. Please do not dismiss this as something benign until the patient gets at least a well done ultrasound. Any axillary swelling needs to be investigated because sometimes we can find axillary lymph nodes, lymphadenopathy, although there are no palpable masses seen in the felt in the breast. So we need to investigate this. And early referral to breast clinic. This is mentioned in our breast cancer management CPG. The latest one is in 2019. That's available on the Academy of Medicine. It is advised that women above 35 with signs and symptoms and those in high-risk groups or patients with obvious signs of malignancy need to get urgent referral to the nearest center. Okay. So I mentioned this just now. And how do we diagnose breast cancer? Now, yes, we do find that there are lots and lots of screening centers doing blood tests and tumor markers in the hope of looking out for breast cancer. However, the diagnosis of breast cancer is only by triple assessment. That is by history, very thorough history taking, clinical examination, imaging, either with ultrasound or plus mammogram, pathology, biopsy results. These are the ways where we diagnose breast cancer. We need all in total. The blood tests of tumor, which are done for some women, the tumor markers. We do use the tumor markers to monitor patients who have been diagnosed with breast cancer before, because if we do see any change, any elevation of, say, CA125, CA or CA153, we may investigate further to look at whether the patient has a recurrence or metastasis. But it is not used for the diagnosis of breast cancer. I've seen many women who've had screening done with obvious cancer where the tumor markers are absolutely normal, within the normal ranges. So please don't be swayed by a normal tumor marker result. So what happens in a breast clinic? As I mentioned before, thorough history taking, personal history. We need to take family history of any cancer up to second or third degree. Sometimes patients need a bit of digging, and a lot of times they do not actually know their family history. So I usually tell them, okay, next time you meet up with any of your relatives, please ask details when they were diagnosed. That's the important factor. If they have any relatives with breast or ovarian cancer or prostate cancer, we need to know the age of diagnosis. And physical examination must include both breast and axilla. Now, if we find that the patients have some family history, we can recommend them to go for genetic counseling prior to genetic testing. Now it's ever so easy to go and send your blood or a buccal smear or saliva to do genetic testing. But I must caution all of you that we need to tread this carefully, because if these results, these positive results where they have genetic mutations, it might affect the patient and their progeny, their children, for medical insurance coverage in future. So please be cautious about this. They need counseling first before they proceed to do their genetic testing. So those who would be advised to go for genetic counseling are those who have history of ovarian cancer or family members with ovarian cancer. Breast cancer in somebody in their relatives, or this person is younger than 45 years old. 2 primary breast cancers in their relatives, both diagnosed at less than 60. Those who have triple negative breast cancer, male breast cancer in the family, and any relative with the above criteria. So these would be patients would be recommended to go for genetic counseling. So combined mammography and ultrasound does improve breast cancer detection. I know that screening tests frequently limit just ultrasound of the breast for women below 40 and just mammogram for women above 40. However, when I see patients who are above 40, I immediately request for mammogram plus ultrasound, because they complement each other, because mammogram is using low dose X-ray and ultrasound is high frequency sound waves, and we actually improve on early detection. So a lot of places in Malaysia now in the bigger towns have the 3D mammography, the digital ones, and they are certainly much better than the analog mammograms of yesteryears, and they are also less discomforting to the patient. When patients turn up for mammogram, we advise them, if it's for screening, it's best to have it done mid-cycle when the breasts are soft. Even for ultrasound, sometimes for certain views, the radiologist would need to apply a little bit of pressure when they're doing the ultrasound. Hence, it is better that women come during mid-cycle, or you can tell them after their period is over. So I mentioned earlier, for triple assessment, we need a biopsy result. So we have found that core needle biopsy, either using the needles gauge 14 or 16, is a much better tool for diagnosing both palpable and non-palpable lesions. If they are non-palpable, we get the cooperation and assistance of the radiologist to do them under ultrasound guidance, or some of us breast surgeons are able to do ultrasound guided biopsies. FNAC. Now, the problem with fine needle aspiration cytology is, number one, you can't give the patients local anesthetic. Number one. Number two, the cytology needs to be reviewed in the pathology lab by cytopathologists. As I understand it, we do not have enough cytopathologists in Malaysia, and most of the specimens are reviewed by general pathologists. So I believe that it is better to give the pathologists a larger sample. Core needle biopsy, the specimens are not that big. It's only about 2 to 3 millimeters, and the thickness is about 1 to 2 millimeters. The length is about 5 millimeters. So with that size of specimen, not only are we able to do the histopathology, the H&E stains, we are also able to do the immunohistochemistry, the ER and PR status, which is really important for us, because also for the oncologist to individualize treatment according to the receptor status. And we can at the beginning, inform and counsel the patients. As breast surgeons, we are able to counsel the patients what their journey of treatment would be. Now, apart from the estrogen receptor and progesterone receptor status, we would like to do the HER2 test. Now, HER2 test, if we send it for immunohistochemistry, the result comes back as either negative, 1+, 2, 2+, or 3+. 3+ is considered HER2 positivity, which means that the patients would have the opportunity to have Herceptin as part of their treatment in breast cancer. So if the HER2 test is gives a result of 2+, we can then send the specimen for FISH testing to confirm whether it's HER2 positive or negative. Now, from the ERPR and HER2 results, these are the molecular subtypes of breast cancer: the luminal A, luminal B, HER2 overexpressed, and the basal-like tumors. The most aggressive is the basal-like triple-negative tumors. The ERPR negative and HER2 positive types are also can be just as aggressive. So, what are the challenges in diagnosis? So, before we treat our patients, we need to understand the challenges in diagnosis. Number one, when patients come, trying to get them to be aware that their breast lumps need to be investigated is a big effort, and it's a continuing effort on all parties involved, from the public to our GPs to all our doctors. We need to be more aware to this cancer that really burdens women all over the world. Unfortunately, we know that there is lack or reduced access to consultation because the majority of breast surgeons are in Klang Valley. Please look into the National Specialist Register when you want to refer to breast surgeon. Look for the list under breast and endocrine surgeons. You will find the list is listed according to state, and if patients have an issue seeing a male doctor, you can choose for them, refer them to females if they are okay with it, whichever appointment that is the fastest, do refer. I do understand there is delay in getting imaging investigations. I have been informed by patients when they go to public hospitals, they are told at the surgical departments or the breast clinics that the staff informs them, if you want it quick, go and get your mammogram and ultrasound done in a private hospital or a private screening center. That's okay for patients who can afford, but unfortunately for those who can't, there will be delay in getting this initial imaging done. Now, biopsy results. Now, for most Klang Valley and in the larger cities, we get results within a week. Where I work in 2 hospitals, I can get the results within 24 hours. And of course, once we've gone through all the counseling with the patients and suddenly at the end, they say, no, I don't want to do a biopsy. And there is this widespread belief that once we do a biopsy, the cancer will spread faster. I think we need to shut down this belief. Unfortunately, there are also some medical personnel who spread this misconception that once a biopsy is done, the cancer spreads faster. I think this is utter rubbish and irresponsible for some individuals to inform patients that we don't need to do the biopsy. We can do the operation straight away. The trouble with excising a suspicious lump that already shows suspicious malignant features on imaging is, if you do a lumpectomy, number one, you run the risk of not getting enough surgical margin, not inadequate. Number two, after you remove the cancer, you will need to go in and assess the axillary lymph nodes. At the least, the patient would need to have another surgery involving the sentinel lymph nodes. So in the end, the patient having 2 surgeries under general anesthesia. So please, we need to have the biopsy done first so that we can properly counsel our breast cancer patients. So I'm almost at the end of the first part. So let's look at question 1. A 24-year-old lady presents with a non-tender palpable breast lump. She can feel it. She took a week before she came to see me, and she told me that her paternal aunt had breast cancer at the age of 29 years old. Now, having a relative with breast cancer, it doesn't matter whether maternal or paternal, at such a young age should be red flagged already. You see, the signals should be up. So how would you advise and investigate her? A, sending her for an ultrasound of both breasts. B, inform her that her ultrasound breast will be done, but if the lump appears suspicious, a mammogram will be done, followed by a core needle biopsy. C, sending her for a mammogram, followed by a core needle biopsy. Or D, tell her not to worry, she's too young to have breast cancer. Let's see your answers. Would you like to share your answers? Let me inform you then. You should do B. Sorry. Sorry about that. It's just a phone call. Okay. So the answer is B. Now she's 24 years old. She has an aunt with breast cancer diagnosed at 29. Send her for an ultrasound, but right at the beginning, inform her that if the lump looks iffy, looks suspicious, she will need a mammogram followed by a needle biopsy. I think upfront, we should actually tell the patient to be prepared, yeah, for a biopsy. Okay. Question number 2. A 45-year-old lady felt a centimeter lump a month before her appointment, and she's got no family history of any malignancy. How would you advise her? A, send her for blood tests for tumor markers. B, mammogram, then core needle biopsy. C, mammogram, ultrasound breast, then a core needle biopsy. Or send her for a CT scan. Well done. Most of you have answered C. She's 45 years old, above 40. The mass is big, it's 3 centimeters. You don't have to have a family history. She might be the first one in a family to have a breast cancer. So please send her for mammogram, ultrasound breast, and for a core needle biopsy. Thank you for participating. Dr. Saunthari, shall we take a short break or shall we continue?
I think there are a few questions for you, Azlina, so
Yes,
if
yes.
you don't mind. The first question is actually from me to your question 1.
Okay.
Considering that her paternal aunt had breast cancer at a young age and she's 24 years old, yes, with a non-tender palpable breast lump, but would you consider some sort of genetic counseling or genetic screening with that as well?
Yes, I would, after we get the results.
Okay. If the results are even negative, that it's not breast cancer, would you still go down the path of genetic counseling and screening?
I would, but I wouldn't I wouldn't insist on it. I will inform her to think about it, and to also not forgetting to tell the rest of her family members to go for screening.
Okay.
Yeah.
Yes. There is another question here on genetic screening. It says, Doctor, what does primary breast care in genetic testing slide mean?
Let's go back. No. Say that again, Saunthari.
What does primary breast cancer in the genetic testing slide mean?
Oh, okay. Hang on. Oh, okay. This one, right? Primary breast cancers? Yeah.
Yeah.
Okay. So, if there are 2 family members who had breast cancer, who had cancer originating from the breast, and these 2 relatives were less than 60 years old. I hope that answers the question, because sometimes some people do get confused whenever you ask patients. You say, "Oh, I have a relative who had breast cancer. Also, after that she had liver cancer. After that she had brain cancer." So we need to find out where the primary was, and if we get some information that they've 2 relatives with primary breast cancer less than 60 years old, I think there is enough evidence to advise them to go for genetic counseling. Okay,
thanks.
Okay.
You had a slide, I can't remember now, just before this or just after this, on the luminal, basically I think what is interesting, I mean, you've been in this line for so long, and I as well, you know, talk a little bit about breast cancer here and there. I think what is interesting is that in a way, we've had to throw out a lot of what we learned about breast cancer earlier on, meaning that when we looked at diagnosis, we basically just looked at the size of the tumor, the type of the tumor, where it spread, you know, and maybe the grade, you know, that was what we only looked at in terms of treatment. And then, you know, you staged it, stage 1 to stage 4, etc. And then, you know, depending on your lymph nodes and metastases, then you did treatment. This slide really shows you that, you know, that is out of the window now, and how important the molecular subtypes of breast cancer is, and how important doing immunohistochemistry is in terms of how we treat. And I know you're going to talk about treatment later, but I don't think everybody is as aware of how important now it is to get all the other peripheral information about the breast cancer so that we can actually target treatment better.
Yes. Frequently, we do get patients who have had biopsies, but the pathology request for the histopathology is often just histopathology, asking for HPE once the biopsy is done. And sometimes there is a little delay because we have to request for the immunohistochemistry, the estrogen receptor, progesterone receptor, and the HER2 status. Why I say that this is really, really important is because now the current guidelines say that even if the tumor is 2 centimeters, if the tumor is ER negative, PR negative, triple negative, or ER/PR negative, HER2 positive, it is better for the patient to go for neoadjuvant chemotherapy and targeted therapy prior to surgery, because it gives them a better outcome and progression-free disease. So these are the options that we need to discuss with patients to give them a better outcome. It's not just, you know, let's get the tumor out. We need to counsel them. And I do find now and then whenever I send patients to, you see, the decision is not made just by the breast surgeon. In good centers, we have multidisciplinary teams involving, and I will talk about this later on as well, where the decision is a joint decision. If in doubt, or sometimes almost for every case, I discuss with the oncologist, shall we give a neoadjuvant and targeted first, or is it okay for me to, take out the tumor first? All these things need to be put into consideration because one can't know everything. Yeah.
Yep.
So we need to find that something wrong here. Okay, not everything. Sorry, even in the last 5 years, there's been a lot of changes. So we want to give our patients the best outcome as possible. Yeah. Yep. Okay. All right. So.
Okay. Yeah. I think that's important to note, because at diagnosis sometimes, and it's not at a breast surgeon, it's a general health professional in most instances.
Yes.
A lot of the patients are told that, oh yes, it's a small tumor, we're just going to do a little bit of surgery and you take it out and that's it. And then once you go to the breast surgeon or you go to the oncologist, and then there's stated that no, maybe you have to do chemotherapy first or something to that manner, then a lot of doubt gets into the patient. Yes. They lose confidence in terms of, they've been told something before and now you're telling me something different, etc., etc.
Yes. So that's why we need to improve on our awareness. And if we are not sure of what the management would be, I feel it is best to refer the patient to reduce this suspicion of healthcare professionals, because they will say, but how come that doctor told me this, and now you're telling me this? So it takes extra effort for me to show the evidence that's available online, and I don't think that it's totally wrong, but when we have all the resources, I want to give the best to the patient. It's not just, like I said earlier, just getting the tumor out. Also, due to newer methods for very early breast cancer, which I'm going to talk about also later, you might be taking away the opportunity of the patient of getting this method called intraoperative radiotherapy. So it can be like a one-stop treatment. So it's sad that you take away the opportunity for the patient, and due to that, the patient has to come for external beam radiotherapy every day for a month. So you could have reduced that burden on the patient, but due to hesitancy and that need to, let's treat it ASAP. Now, believe you me, once a patient is diagnosed with breast cancer, you can actually give them time for about 2 weeks to think about how to plan their activities, because I always tell women, you're not just your boobs, you have a responsibility probably as a partner, as a mother, as an employee, to plan your time before you come in for surgery, so that I don't want them in the hospital bed thinking about who's going to pick up the clothes, who's going to wash the clothes, who's going to do the shopping, who's going to do the ironing, etc., who's going to cover for my work. I think we need to reduce the mental stress on the patient by giving them that little bit of time to plan their life, while we are trying to treat them. So you don't need to rush into things. It's not gonna, I tell them, it's not gonna explode in your face.
Okay, there's a second question here. Is a triple negative breast cancer with axillary nodes but no distant mets in a 72-year-old postmenopausal woman considered aggressive? So,
triple
72 years old,
Yes, triple negative breast cancer is always aggressive. Is always aggressive. Yeah.
So irrespective of age, you're saying?
Yes, yes. regardless of age. I've seen triple negatives in an above 60-year-old, and boy, was it aggressive.
Okay. What would you consider to be the 5-year survival rate?
I haven't looked it up recently, but with better chemotherapy, Saunthari, that's a question for oncologists. But saying that, I've had patients who've had chemo and triple negative, and praise the Lord, she has gone beyond 10 years.
All right. So when we talk about, aggressiveness,
it's also discovering early.
Yeah.
If the tumor is small, but if they come above 3-4 centimeters triple negative, the recurrence rate is the highest in the first 2 to 3 years, even with chemo.
Okay. And there's another question which is asking, can you just speak a little bit more about male breast cancer?
Okay, male breast cancer. Now, with the males, most people say they don't have breast. They do. They have breast tissue below the nipple areola complex. You see, the nipple and the areola is considered a complex of its own. And for men, it is very, very frequently behind the areola. It presents as a lump, or it can present as an ulcer. So please, if you have male patients who have lumps at the nipple, especially if they're above 50, do refer them for an ultrasound at the most minimum. Send them for ultrasound. Of course, the more obese gentlemen, you can send them for mammogram even. Okay, so we investigate them in a similar way. If the mass looks suspicious on ultrasound, we will biopsy them, and the treatment will be similar to women. Now, generally, male breast cancer is found in men above 50 years old. If you do find males with breast lumps at the age of between 15 to maybe 25, they are frequently just having gynecomastia, but as a routine, I do send them for ultrasound because you don't know what you can feel. It may not be what can be seen on ultrasound imaging. Now, with male breast cancer, it is frequently more aggressive. Why? Because most of the times the patients don't think they will ever get breast cancer, because they say, but I'm a man, I can't have breast cancer. It's a disease of women. So the percentage of incidence is between 1 to 2%. On my follow-up, I have 2 ladies whose fathers had breast cancer. So it's very high risk. If you do find any of your ladies, patients who have fathers who have had breast cancer, or members in their family who are male and had breast cancer before, they are at high risk for breast cancer. So they are treated, managed in the same way as women. Underreported most of the times because they come late. Yeah, they come late for presentation.
What I found interesting about male breast cancer, I think as well, is that when we talk about risk factors, yes, we know they're similar to female breast cancer, but other than liver disease, that if men have liver disease, so those who drink a lot of alcohol or obesity, etc., their risk for male breast cancer increases as well.
Yes.
And that's something which is not really talked about a lot, because we talk about, family history, etc., etc. But, you don't talk about other risk factors which are more specific to male breast cancers.
It's alcohol is also a risk factor in females, but I guess in men, when there's alcohol, liver disease associated with alcohol, the men get gynecomastia, a lot more volume to their breasts. So yes, there is an increased risk because there is higher levels of female hormones running around.
Yeah. Okay. So if we're all ready for the next section, Dr. Azlina will be talking about treatment options for early breast cancer, and as well as the challenges in the management of breast cancer. And again, Azlina has also posted us some questions at the end of it. So to all our participants, be ready to be questioned. And please do send us a lot more questions as well for Dr. Azlina.
Don't worry if you get it wrong. We won't hold back your points. Okay.
Okay, to you.
Yes, thank you. Moving on, staging of breast cancer. So clinical staging is the results of the tests done before surgery. So we already know the size from the mammogram, ultrasound, and occasionally we need to do MRIs. The pathological staging, however, is based on what is found on during surgery when we've had the opportunity to remove the breast tissue and the lymph nodes. And these results are usually available between 3 to 5 days after the surgery. So this is staging of breast cancer. Yeah? So how do we go about it? So tumor size. We look at the tumor size, we look at involvement of lymph nodes, and we look at metastasis. Now, frequently breast cancer loves to metastasize or spread to the liver, the lungs, and the bones. Hence, once we diagnose the patient to have breast cancer, then we can do the staging, which includes, now, if we do have CT scan facilities, we send them for CT scans from the neck to the pelvis, including the ovaries, because once in a while we do get Krukenberg tumor, which is breast cancer that metastasizes to the ovaries. So we have a look at the ovaries as well. Also, it gives us the opportunity to look at the uterus. Because if we need to give the patients hormonal treatments, some hormonal treatments like tamoxifen may cause thickening of the endometrium. So we do have an opportunity to have a look at that. So TNM staging, however, it does get complicated over the years. The AJCC, the American Joint Committee on Cancer, latest edition is January 2018. It looks very, very confusing, and I apologize for this busy slide, but what it includes is the size of the tumor, the lymph nodes, yes, the metastases, yes. It also includes the estrogen receptor status, the progesterone receptor status, the HER2 status, and the grade of the cancer. Now, grade can only be discovered by the pathologist. Now, grade is divided into nuclear pleomorphism, the mitosis, and also the features seen on the breast cells. Yeah, so grade is grade 1, grade 2, grade 3. Now, if a patient has a small tumor but the grade is grade 3, is aggressive, we do have to caution patients and inform them that they need to be on closer follow-up. And sometimes if they have grade 3 tumors, the oncologist may advise chemotherapy or more aggressive treatment for them. So this is another view of the AJCC. And we'll go quickly into the treatment options for early breast cancer, which was the original topic of this talk. So treatment for early breast cancer does involve some combination of surgery, radiation, chemotherapy, hormonal therapy, HER2 targeted therapy, and occasionally immunotherapy. For non-metastatic breast cancer, early stage 1, 2, 2A, 2B, and locally advanced is when the tumor is larger than 2 centimeters but less than 5, but with no lymph node involvement, or stage 3A to 3C. In the CPG management of breast cancer, early breast cancer does include ductal carcinoma in situ, which is stage 0 up to stage 2B. Now, this is in our latest CPG, which was published, which was prepared by the end of 2019, and it is available on the Academy of Medicine website. So patients with early breast cancer are frequently asymptomatic. They have totally no symptoms and they may pick up on screening. So they have routine imaging screening for mets should not be performed. I don't quite like the word routine because nothing is routine really. When we deal with breast cancer, we need to look at individual risk factors. If they have signs and symptoms of lung, liver, or bone secondaries, then we should perform blood tests and at the best some CT scans. Occasionally, we might want to do PET CTs. Now, these would not be early breast cancer then. Okay, so this was mentioned in the CPG of management of breast cancer. You can find this also in the CPG, the algorithm for management of early breast cancer and locally advanced breast cancer. Now, this is something that has come up in the studies were done in the late 90s, and in the early 2000s, they did a multi-center trial looking at the benefits of intraoperative radiotherapy for early breast cancer. Now, for the target A criteria, the patients need to be above 45 with early breast cancer, not affecting the pectoralis fascia or pectoralis major muscle, which is underneath the breast, at the base of the breast. So what this does is we use the IORT device to emit X-ray radiation to the cavity of the breast after the cancer lump has been surgically removed. This is all done under general anesthesia. So with this one-off treatment, the patient can avoid going for multiple visits of external beam radiotherapy. So what is usually done is the cancer mass is removed, but the surgical technique of removing breast cancer for women that is planned for IORT is slightly different. We have to excise a cavity that is somewhat spherical so that we can place the sphere, the applicator, which is a ball-shaped applicator. The tip itself is the one, there is a little pin there in the middle that will emit the radiotherapy for the procedure. And then the patients are given IORT of 20 grays, and depending on the size of the cavity, the duration of the IORT is between 20 to at the most maybe 40 minutes. And during that time, we get out of the operating theater. The patient is monitored via CCTV. The anesthetist sits somewhere else to monitor the patient. And then once the IORT is completed, we remove the sphere and the cavity is sutured. Yeah. So what are the benefits of IORT for early breast cancer? Now, patients who fall under the criteria target A are above 45 years old, early breast cancer, non-metastatic. They need to be ER positive and HER2 negative. Now, if the patients have breast cancer, which are when they are either they are younger than 45 years old, or they have ER negative or HER2 positive breast cancer, they fall we do find lymph node metastasis, they fall under the criteria B. Now, those under target B criteria not only do they get this one-off IURT, but they do actually need to have subsequent external beam radiotherapy. So for those early breast cancer, the treatment can be completed in one sitting. Means the cancer mass is removed, the lymph nodes are assessed by sentinel lymph node biopsy, and then IURT is given, and that's it. You know, the subsequent treatment may involve just oral hormonal tablets and no chemotherapy. So the timing of radiotherapy at surgery is really beneficial. There is no delay whatsoever. It also reduces the workload of radiotherapy units. It allows women from remote areas. Then in Malaysia, there is no radiotherapy services in some states, and women would have to travel to come for radiotherapy treatment. So this is also perfect for medical tourism for patients with early breast cancer. They come in, get the surgery done, IURT done, and off they go with medication for hormonal, oral hormonal treatment. Number 5 is geographical miss. What is geographical miss? Now, after a patient has the conventional lumpectomy and axillary node surgery, and the wound is closed, if the area where the tumor was not identified by Liga clips, some surgical clips left in the cavity, the subsequent radiotherapy given externally can be targeted at a different area. So when we do IURT, we avoid this geographical miss because the radiotherapy is given to the actual area after the cancer has been removed. So this is the great thing about it. Also, patients have a better cosmetic outcome. Frequently, patients who have external beam radiotherapy do get some radiation dermatitis. There can be hyperpigmentation, there can be thickening of the skin, they can have some ulceration in the worst case scenario. So when we give them IURT, we prevent all this from happening to the lady. Cost saving in terms of the total cost of external beam, the traveling to the radiotherapy centers, etc., we do find that it does reduce the expenditure for the ladies. As I mentioned before, managing breast cancer patients is not a one-man or one-woman job. We need a whole team. And I mentioned this repeatedly to patients that I cannot do it alone. What happens in real life is the radiologist detects the suspicious mass, the surgeons assess the mass, decides on biopsy, whether the patient needs image-guided biopsy. If the mass is too small and non-palpable, then the pathologist has a look at the specimen, and then the patients are eventually, or prior to surgery itself, where some patients need neoadjuvant treatment, they are referred to the oncologist. We do get support groups involved to give moral support to the patient. We get NGOs like National Cancer Society and Breast Cancer Welfare Association who have trained counselors. We even have breast care nurses that have gone for courses to help with the counseling of the patient. We need to get the family involved if the patient allows it. There are some patients who don't want their family to be involved, and we need to respect that, although we can advise that it is better if we get your family involved. And if despite all our efforts that the patient progresses in terms of their disease into stage 3 or 4, we need to get the involvement of palliative care physicians or hospice setups to help the patient to plan for the rest of their days. So, I've spoken about management of early breast cancer. What are the challenges? There are many challenges, you know. So, the evolution of breast cancer management in the past, for any size tumor, the patients had radical halted mastectomy, which was very disfiguring, where not only the breast was removed, the underlying pectoralis major and minor muscles were removed, and what was left was a scar, and externally you can even see the patient's ribs because the muscle was removed. And then the evolution from the radical mastectomy was replaced by modified radical mastectomy, where we do not remove the muscles. And eventually we are going more and more into breast conserving surgery, because we have had the opportunity to give the patients neoadjuvant treatment to reduce the size of the initial cancer to a size where lumpectomies are possible. And we have also reduced morbidity with regards to lymph node surgery. In the past, when we do axillary clearance, even for the smaller cancers, we do find that the risk of lymphedema, swelling of the arm due to obstruction of the lymphatic channels was about 20 to 30% of the women. We have managed to reduce that, where for early breast cancers, we do sentinel lymph node biopsies, so that we don't have to remove so many lymph nodes. The sentinel lymph node biopsies, the guidelines say that you only need to remove between 1 to 4 lymph nodes to send them for frozen section, so that if there are no lymph nodes seen in these sentinel lymph nodes, we don't have to go for axillary clearance. Also, in the last 20 years or so, there have been improvements to reconstructive techniques, where if patients need or are agreeable for total mastectomies, we perform immediate reconstruction, either breast surgeons working together with plastic surgeons, or breast surgeons who have been trained in oncoplastic techniques. We as a group, we perform these reconstructive procedures to improve on the outcome of the patients, to improve on mental stress, and to allow them a smoother transition into their future life and employment. So those are the things that have come up in the last 20 years. What are the challenges to the patients? Now, you know that the C word is such a bad word. Yeah. Once we break the news to the patients in the clinic that they have cancer, you get all sorts of reactions. Some who have actually suspected that they have breast cancer are more calm, but we have to get our breast care nurses involved in assisting them to take charge and to assist them in planning on what to do next. They have that sense of mortality because breast cancer affects their body image. Not many women can get through this initial moment of, yes, they are still the person they are. We need to just treat them in a way that doesn't impact so much on the body image. And that is possible if we detect these cancers very early. They start thinking about side effects. They get a lot of feedback from their well-meaning friends and relatives, or you can't do this and you can't do that. And we need to go deep into discussion on women, on what they can and cannot do, and tell them that you don't need to go on a strict diet. And in fact, that might jeopardize their treatment because they have lost so much protein due to severe dieting. We have to also assist them in their employment issues. Frequently, I've had to write many medical reports telling them that the patients are able to continue working after their treatment is over. this is a big issue, relationship issues. Now, if we find that patients actually have good family, moral support, partner support, spousal support, they actually do better in their treatment and recovery. And of course, as I mentioned a little bit earlier, the financial catastrophe is quite amazing. We do find that patients can't pay for all of their treatments. Unfortunately, some insurance companies do not pay for outpatient care, and that includes their oral hormonal medication. And we've had to help patients by writing letters that this is part of their treatment. Just because it's in oral form, they need to have coverage for that, because the hormonal treatments are actually for 5 years or more, and that can cause quite a dent in their savings. Now, so what are the remaining questions that we need to look at? Now, Bernard Fisher wrote this paper on preoperative chemotherapy, neoadjuvant chemotherapy, basically, on a model for studying the biology and therapy of primary breast cancer way back in 1995. And also, he was part of this study in 1990, published in Journal of Clinical Oncology in 1997, talk on neoadjuvant chemotherapy. So with patients who have had sentinel lymph node biopsy, we do wonder whether it is adequate to not remove the rest of the lymph nodes. Also, patients who still have positive lymph nodes following neoadjuvant chemotherapy, they will need further axillary clearance. We also know that nowadays, with more and more papers coming up, neoadjuvant chemotherapy has become standard of care for patients with locally advanced breast cancer, and it's a reasonable alternative to adjuvant chemotherapy with large operable disease. So even if we find that the patients have, for example, a tumor which is 3 centimeters, and it does not involve the pectoralis major muscle, we do find that the outcome is much better if we subject them to neoadjuvant chemotherapy to reduce the size of cancer before the definitive surgery. Yeah. What else that we need to look into? So apart from more active neoadjuvant chemotherapy regimes and novel molecular and imaging techniques, we need to, this will lead to individualizing local regional treatment, including there has been some studies showing where if there is only micrometastasis in the sentinel lymph nodes, okay, do we proceed to do axillary clearance, or we can just make do with just the sentinel lymph node biopsy? That's one question. The other issue is, can we avoid removing the initial tumor and the lymph nodes in patients who do not have detectable cancer in the breast once they have completed their neoadjuvant treatment, which may include chemotherapy and targeted therapy? Can we avoid surgery altogether? So this is the question for the future to be addressed, because with pathologic complete response, or PCR, when we remove the initial site that can be detected by putting in a biomarker at the time of the biopsy to denote the original site of the cancer, if the patients go through chemotherapy and all that we see later is just the clip without the mass, in future, are we brave enough to leave the original tumor behind? So this is a question for future studies. Right, I basically ended with the talk itself. Shall we address some questions first, or shall we go to question number 3, Saunthari?
I think if you can go to question number 3, and I'll ask all the participants to please post their answers on the chat.
All right. So question number 3 is, we have a 63-year-old lady who has a 3.5 centimeter left breast lump. On biopsy was confirmed to have invasive breast cancer, ER negative, PR negative, and HER2 positive. What would be your advice? A, tell her you need a mastectomy with axillary clearance. 2, propose and advise neoadjuvant chemotherapy with targeted therapy with a high chance of breast-conserving surgery, which is a lumpectomy. Give her oral hormonal treatment. Or D, tell her you're too old to have treatment and not suggest treatment at all. What would you advise her?
So looking at the chat, Azlina, you've got majority Bs, but there's been a few As as well.
Yes, yes. And why I put up this question was, this is a patient of mine who had gone to another breast surgeon, and she was advised to have a mastectomy with axillary clearance. She asked the surgeon, can my breast be saved? Now this lady, now when we look at possibility of breast-conserving surgery, we look at the size of the tumor compared to the size of the breast. Now this lady had a good sized breast. She was probably a 36D cut or E cut, and she was told, no, you are 60 plus, you don't need your breast. Okay. Now, and this lady decided to seek second opinion. She came to me and she had all the immunohistochemistry done, ER negative, PR negative, or HER2 positive. And I informed her that I will send you for an assessment, cardiac assessment, and some tests first to see whether she would be suitable for neoadjuvant chemotherapy with targeted therapy, and we could actually have a chance of doing breast-conserving surgery for her, which is what she was happy enough to hear. Now, this lady went on to have neoadjuvant chemotherapy with targeted therapy, and the tumor shrunk so much that it was hardly noticed. I went in to do a lumpectomy, which is wide local excision, with sentinel lymph node biopsy. No lymph nodes affected, and she had a PCR. She had a pathological complete response. There was no tumors seen. So, and this lady had no other comorbids. You know, she didn't have any diabetes. She was normotensive, no other medical issues. So when you have a patient like this, I think we need to explore other options where we can preserve the breast. Yeah. And telling a woman she's above 60 and she's too old to have surgery or too old to have neoadjuvant chemotherapy is without any basis, unless you have found some comorbids in her where you know, it would be more suitable for her to have a mastectomy axillary clearance. You would have to address the options. Of course, at the end of the day, sometimes some patients actually opt for mastectomy with axillary clearance. Now, in this lady, if we do stage, if staging has been done and there are no visible lymph nodes on the CT scan or on the ultrasound, we can proceed if she wants to do a mastectomy, but with sentinel lymph node biopsy. Yeah. Next question.
So sorry, Azlina,
Yes.
to that question 3. So basically, I mean, because there's quite a few people who have answered A in this. So basically what you're saying is that the only main deterrent to doing the neoadjuvant chemotherapy would be the comorbidities aspect of it.
Correct. Correct. Yes.
Yeah, so if she didn't have the comorbidities, the age is not an issue whatsoever. But even if she did had comorbidities, we would have to basically look at the personal risk status of that person, isn't it? It's not a blanket that, oh, if you have comorbidities,
no, not a blanket rule. Yeah, we get the collaboration of our team members. You see, I would include a physician, could be a cardiologist or a general physician, to look at her general status and whether she's fit for surgery. And especially since she is HER2 positive, we would be planning to give her targeted therapy, and we know that her septin can, in the elderly, cause some cardiomegaly. So we need to look at all those aspects before we commence them on targeted therapy. But if everything's clear, there is no problem with giving neoadjuvant chemo with targeted therapy. So it's just, we need to explore. We shouldn't just at at the start be quick off the mark to say, oh no, she's 63, she just needs a mastectomy and clearance and be done with it. Because we have the papers have proven now and again that the progression-free disease is much better with neoadjuvant chemotherapy in certain subtypes. Yeah.
Okay. Sorry, I'm just pushing on to this question as well, that if this patient, you just mentioned subtypes, that it's better with certain subtypes. So if a lady came to you, say 63 years old, the same, a smaller breast lump maybe, noted to be invasive, but with an indeterminate type of cancer, ER negative, PR negative, HER2 positive, would you also say neoadjuvant chemotherapy? Would that indeterminate subtype make a difference? I mean, that indeterminate type of cancer, would that show in terms of the aggressiveness of it? Would you think it in that way?
If the tumor is smaller but larger than 2 centimeters, the guidelines say that the patient would be suitable for neoadjuvant chemotherapy. If ER/PR negative and HER2 positive tumors actually respond very well to neoadjuvant chemotherapy, and the HER2 positive tumors also to targeted therapy. So what is 2 cm and more, or with involvement of lymph nodes in ER/PR negative, HER2 positive, actually do respond very well to neoadjuvant chemotherapy. The indeterminate type, what do you mean? But it's invasive, right?
It's invasive, but you don't know if it's ductal or lobular or, if it's
the tumor biology is ER/PR negative, HER2 positive. It doesn't matter the anatomical type. We advise them to have neoadjuvant.
Does it matter in terms of the grade?
In the grade? Okay. Now, if the patient has grade 1, but ER/PR negative, that's a bit of a discordant then, because usually ER/PR negative are grade 2 and above.
Yep.
Grade 2 or 3. We would still explore because ER/PR negative tumors generally do need chemotherapy. So that is the assessment whether they would need you would propose neoadjuvant or adjuvant after the surgery. So they would still need chemotherapy because ER/PR negative tumors are aggressive.
Okay. Your next question then?
Yes. Okay. Okay. Question number 4. A 46-year-old lady presents with a 2 centimeter breast lump confirmed to be an invasive carcinoma ER/PR positive and HER2 negative, which of these would be the current standard of care? So A, sentinel lymph node biopsy with breast-conserving surgery, which is a lumpectomy, followed by intraoperative radiotherapy. B, wide local excision and axillary clearance. C, mastectomy with axillary clearance. And D, neoadjuvant chemotherapy followed by sentinel lymph node biopsy with wide local excision. Okay, we shall look at the answers. So far, I see A's. Oops. Sorry. Oops.
You can't run away that fast, Azlina.
Accidentally clicked. Okay.
Interesting. You've got quite a mix here.
Yes.
One
you know why?
D.
Yep. You know why I included this? Because there's not one answer. Okay, it depends. All right. So now this is a 46-year-old lady, a 2 centimeter breast lump, which is T1 still. Okay. ER positive, HER2 negative tumors are known to be not aggressive. Okay. And which of this would be the standard of care? Now, it depends on the center that the patient is seen in. Okay. Now, if you have everything on board, you have sentinel lymph node biopsy with frozen section facilities, you have IORT, and to have intraoperative radiotherapy, you need to have surgeons who are trained in intraoperative radiotherapy. You need oncologists who are trained in intraoperative techniques. So you go for A. But if you do not have sentinel lymph node facilities and you do not have frozen section facilities, you do not have intraoperative radiotherapy, but you can refer the patient for radiotherapy later, you can opt for B, wide local excision, which is a lumpectomy with axillary clearance. Okay, now C. C is an option, mastectomy with axillary clearance, if, number 1, the patient opts for it. 2, the cancer size in terms of ratio to the breast, the patient has small breast where there's not much normal breast tissue left if you have already excised the 2 centimeters tumor with adequate surgical margins, which means you need to have a excise at least another 1 centimeter, or a 2 centimeter breast lump, you need to remove actually 3 to 3.5 centimeter mass, 3D. Okay, so you end up with a cavity of about 3 to 3.5 centimeters. So you need to imagine that once you remove the lump, can you recreate the breast by your surgical techniques? So it depends on what you are comfortable with. Now, if the patient has small breast, a 2 centimeter lump, after excision, you end up with not much breast tissue left. Therefore, mastectomy with axillary clearance is better. Now, the fourth answer, neoadjuvant chemotherapy followed by sentinel lymph node biopsy. It is also possible, however, we know that ER/PR positive tumors and HER2 negative do not respond dramatically compared to ER/PR negative tumors or HER2 positive tumors. They do respond, but the extent of the reduction in the cyto reduction is not as much as compared to ER/PR negative or HER2 positive tumors. So all answers can be correct whenever, wherever you are. Yeah. So so that's the answer, Saunthari. I see one question here from Dr. Rajwin. Where do we find available clinical trials for novel treatments for different subtypes of breast cancers like ER/PR positive or HER2 positive ER/PR? I presume ERPR negative or HER2 positive besides university hospitals? Can NCSM assist with guiding patients with this? Yes, NCSM, Dr. Saunthari will be able to guide patients to where these services are available. Most hospitals in Klang Valley have this. I will share with you the hospitals that have IORT machines. The IORT machines are available in 6 hospitals in Malaysia. I just double checked recently. In Penang is Loh Guan Lai Hospital. In Klang Valley, we have them in University Hospital, Sunway, Subang, Pantai Hospital Bangsa, where I work, Prince Court, 5, hang on, 1 Loh Guan Lai, UH, Sunway, Subang, Pantai, and Prince Court. Yes, 6 hospitals that have intraoperative radiotherapy for early breast cancer, and these hospitals also have Sentinel lymph node biopsy facilities. Some hospitals use only methylene blue dyes. Some hospitals use double technique, including the scintigraphy, okay, the radioactive material. The papers show that it's equally just as good, okay. So and frozen section facilities. So these are the hospitals that have all the treatment methods that I've mentioned. Yeah, the latest available methods.
I mean, to that question though, Azlina, the question actually says available clinical trials, but I don't think it is necessary to have clinical trials.
No. The clinical trials are over. We have come to a conclusion already. Yeah, so there are trials that involve our local oncologists with regards to treatments, for example, advanced cancers for ERPR positive HER2 negative, or advanced cancers for triple negative breast cancers, the metastatic triple negative and metastatic ERPR positive HER2 negative tumors. There are some oncologists are involved in these international clinical trials. So we could get that information if you want, but some trials are closed. And usually we can get this information probably from the Malaysian Oncological Society. Yeah.
Okay. Azlina, to your question 4 here, you said that, being ER positive, PR positive, HER2 negative is actually a slow growing, less aggressive. I know there are 4 different subtypes. Could you go through it in terms of what is considered to be the best possible to the most aggressive in that sense?
Okay. Let me go back to that slide of the. Okay, here we are. All right. So the luminal A are the best type to have if you have breast cancer. It's the ERPR positive, estrogen receptor positive, progesterone receptor positive, and HER2 negative. This is said to be the least aggressive type. Yeah. The luminal B is when there's estrogen receptor positive, progesterone receptor less than 20%, and still HER2 negative. Okay. There is also the other subtype of luminal B like HER2 positive, where it's slightly more aggressive. Having HER2 positivity is having aggressive breast cancer. But what is the percentage of all women with breast cancer with HER2 positivity is about 20 to 25%. So about a quarter have HER2 positive. When you have HER2 new gene overexpressed, it's called HER2 positivity. So just having HER2 positive is aggressive enough. Then you have the basal, like the most aggressive is the triple negative, ERPR negative, HER2 negative tumors. So having ERPR negative with HER2 positive is also aggressive. and almost equally as aggressive as triple negative
Okay.
in certain situations. Yeah.
I mean, one of the questions was there, which was, what's a good link to read up on breast cancer receptions and the appropriate treatment? Could you just elucidate a little bit about how the different, how different would the treatment be between these 4 molecular subtypes?
Okay, it will depend a lot on the size, the stage, and the age of the patient. Of course, we have to look at all the comorbid factors involved. The treatment itself, usually for those with ER-positive breast cancer, upfront you will tell them that they will need hormonal therapy, which will involve any one of the oral treatments. So for women who are diagnosed with breast cancer pre-menopausal, they will be prescribed tamoxifen. So the current guidelines is the patients need to, pre-menopausal women on tamoxifen have to be on tamoxifen between 5 to 10 years. Okay, so there are papers showing benefits if they are taking it for 10 years. Of course, tamoxifen has its side effects. All drugs have side effects. So one of the side effects is having endometrial hyperplasia, which, if unchecked, can lead on to endometrial cancer. Now, if the patients are postmenopausal, they are prescribed any one of the aromatase inhibitors, and the aromatase inhibitors that are used in Malaysia are generally anastrozole or letrozole. Then patients may be prescribed aromacin if they do not respond to or if they get recurrence with either anastrozole or letrozole, or they have side effects to either or of the initial 2. So that's aromatase inhibitors. Now, for aromatase inhibitors, the women are prescribed AIs for at least 5 years. There are very few papers where it shows benefit beyond 5 years. Yeah, so that's for ER/PR positive. For ER negative tumors, we have to look at the size of the tumor. Initially, if the patient present with tumors larger than 2 cm, I would advise them to go for neoadjuvant chemotherapy first, especially more so if the lymph nodes are seen to be involved. There are enlarged lymph nodes on the mammogram or on the ultrasound. Yeah. Also, if they go for staging CT scans, the lymph nodes are noted to be enlarged on CT scan. Those for HER2 positive tumors, we discuss with them targeted therapy, also with the involvement of the oncologist. If the tumors are small, smaller than 2 centimeters, now the current guidelines for HER2 targeted therapy is any tumor larger than 5 millimeters should be advised on having targeted therapy. So even a 5 millimeter HER2 positive breast cancer will be prescribed some form of targeted therapy by the oncologist according to latest guidelines. So that may sound a bit over, but that's the guidelines now. There are patients with smaller tumors that are HER2 positive that will have surgery first, followed by the adjuvant treatment. So actually, there is no one good link to read because there is so much to
absorb.
Many aspects.
Yeah, the complexity of it.
Yeah. Yes. That's why I advise people don't jump to treatment if you do not have the background to assess the patient well, because if you jump ahead and do surgery, like I mentioned earlier, you might be depriving her of a one-off intraoperative radiotherapy, or if you jump into surgery, you might not be able to give her a one-stage surgery like lumpectomy plus sentinel lymph node biopsy because you've done a lumpectomy already, or you may have jumped into surgery and not given the patient opportunity to go for neoadjuvant treatment, which may help reduce the size of the bulk of the tumor in the patient's body. So we need to assess all aspects, looking at comorbidities as well, and patients' desire. Sometimes they say, you know, doctor, I don't want to go for neoadjuvant chemo and all that. I don't want to go for radiotherapy. What if I just have the total breast removed? Then I would also, even if the patient said, no, I just want the breast taken out, I will still discuss reconstruction and would only back off if they say, no, I don't need reconstruction. I would prefer to have my breast all taken out. So I believe patients should give all the options, then let them decide. You guide them to a decision and not take their word for it. No, doctor, somebody told me it's better to just remove the whole breast and be done with it. Then I will remind them, you won't be done with it. You know, sometimes just looking at the biology of the tumor, you do need subsequent treatment, adjuvant hormonal treatment, etc. There are patients who refuse even just taking a pill a day for 5 years, you know, and I have to warn them that, you know, it's going to recur. And I have a patient on my hand right now, 16 years down the line, she refused tamoxifen. She was premenopausal, insisted that I do not want tamoxifen. And it was a very, very early breast cancer, less than 1 centimeter. And unfortunately, 16 years down the line, the tumor has recurred. You know, so you need to project this what if to them, give them, you know, you have to guide them through their journey, because they don't know. And when you have that experience of managing patients, this is what you can share with them and open their eyes to possibilities.
As you're talking about, you know, us as doctors and stuff like that, there is one more question here about sentinel lymph nodes. If they're clear from cancer, is it confirmed that cancer has not spread anywhere? If you can address that, and then I want to ask you a different question.
Sentinel nodes are clear. Is it confirmed that the cancer? How can we confirm anything 100%? Okay, and if we are so sure of ourselves, we wouldn't tell the patients to come for follow-up. And the standard of care in managing breast cancer is, in the first 2 years, you are actually supposed to follow up the patient every 3 to 6 months, and subsequently 6 monthly. It says there, after 5 years, you can see them once a year. But believe you me, I still see patients that have been under my care for 7 years or so, and I tell them, can you please come back and see me every 6 months for an ultrasound of the breast, because you never know. It can come back anytime, even if they are ER positive. So sentinel lymph nodes clear. To tell you the truth, I never ever tell the patient that you are clear. I never tell them you're in remission. Never. Never.
I understand that aspect of it, but I suppose the question also goes to your whole idea of, you know, what sort of investigations do you do for the patient? So what you mentioned earlier on in your lecture was that if they're small, early breast cancer, if I remember rightly, you actually don't need to do anything more than the biopsy before you actually do treatment. So CT scan is actually not indicated for very early breast cancers. Would you say that's true? Or would you just generally do a CT scan irrespective?
Okay. So that is what is said in the CPG. Because we have to remember that clinical practice guidelines are read by everyone, not necessarily breast surgeons, and we have to think about location of the practitioner, and also the breast surgeons. We can't be dictating, okay, you know, for every breast cancer patient, you must do a CT scan. What if there's no CT scan in that place? So then we would be happy if they get a chest x-ray and ultrasound of the abdomen and pelvis. But if you work in a facility where you are able to do this as baseline, because the patients need to be followed up, I would, at even stage 1B or stage 2, I most probably would order a CT scan, especially more so if the patient is ER/PR negative or HER2 positive or triple negative as a baseline, so that the oncologist will be able to follow them up. The other thing I need to emphasize is that if patients are appear or are confirmed to have breast cancer, we do not do PET-CT scans if they are in the early stages. We do them if they are in late stages or appear to have metastasis. I think we need to emphasize this, because I do find off and on patients in early breast cancer being sent off for PET-CT scan, which is expensive. You know, it is at least 3,000 ringgit per PET-CT scan, and actually is not necessary. So we need to order investigations so that we don't burden the patient so much with the financial side of it. So the investigations that we do, we need to project what are we going to follow up, and understanding a bit about the biology of tumor prepares us to have a baseline to compare with, say, in the next 6 months. Now, oncologists, if the patients are prescribed neoadjuvant chemotherapy, they are frequently sent for a repeat CT scan after completion of the neoadjuvant chemotherapy, because that gives us an idea of the response. Yeah, so they tend to order, especially in advanced breast cancers, they do a repeat PET-CT scan after completion, and sometimes after 6 months of diagnosis.
Okay, so to this whole question about the sentinel lymph node, so if you've done a sentinel lymph node and it's negative, and you've done the surgery, but you haven't done any other investigations prior to surgery, meaning that you haven't done the CT scan, or maybe you haven't even done an ultrasound, or whatever, would you do one after the surgery just to ensure that there are no mets, that there isn't any other disease?
Okay.
Or would you look for symptoms?
Okay, so for a patient that I've already operated for early breast cancer, they are, after they heal from surgery, and even if they are not having any chemotherapy, I see them 6 months after the surgery, and I actually request for an ultrasound of the breast, which includes the axilla, to look at. Every ultrasound breast includes an axilla, and for all breast cancer patients, I tend to order 6 monthly ultrasounds.
Okay, liver ultrasounds as well, or not?
Sorry?
Not necessarily. Liver as well, or just breast?
Not as a routine. Not as a routine. Yeah.
Okay, we're running out of time, so there's a couple of other questions. One is that how often should you be doing your 3D mammogram?
Okay.
I saw that somewhere. Yes.
Okay, is this a screening or for
screening?
Screening. Yeah. Okay. In terms of we go back to the history. Okay, so if patients do not have any family history and they are between 40 to 55 or 60, no other risk factors, and they've had children, they've breastfed, never been on hormonal treatment, etc., and their ultrasounds show normal breast, I tend to send them for mammogram every 2 years. Now, if they do have high risk factors, depending on their age, because the commonest age group for breast cancer is between 40 to 55, I do occasionally, depending on the individual, send them for annual mammograms. Now, if they have high risk, yes, I send them for mammograms, but all my requests for mammograms are inclusive of the ultrasound, because there are features that you can see on ultrasound, but you can't see on mammogram, and vice versa. For example, microcalcifications cannot be seen on ultrasound or MRI breast. Okay, so on mammograms, white dots of microcalcifications, it's important for us to look out for the pattern of the microcalcifications, whether they are clustered or loose cluster or just discrete randomly placed microcalcification. On ultrasound, we are able to differentiate whether a white opaque mass on mammogram is solid or fluid. We are able to measure on ultrasound, so I tend to order them together. And if the patients are followed, I see them 6 monthly ultrasound and annual mammogram and ultrasound for breast cancer survivors. Breast cancer survivors get annual mammograms, annual digital mammograms. Yeah.
Okay, we're running out of time, so I have one question more for you, and that's basically post-treatment. Yes, you know, you see the patient every 6 months or 1 year, etc., but what is the role of the family doctor in terms of the care of someone with breast cancer, even if they haven't actually gone to their family doctor for breast cancer? So if they're going there for other comorbidities, etc., what would you say to that doctor?
Okay, for the GP or the family doctor, if you do know of any of your patients who have breast cancer, I think it would help if you ask them, when was the last time you went for a follow-up with your surgeon or your oncologist, and are you taking any medications, and find out whether they are compliant on the medications. Patients on tamoxifen actually need pelvic examination and pap smears pelvic examination every 6 months, basically, to look out for endometrial hyperplasia. So if you are equipped with ultrasound and you detect a thickening of the endometrial layer, do direct them to breast surgeons or their oncologists or to the gynecologist for further action. They may need a biopsy or a DDNC. Yeah. For other things, to look at the site of the original cancer, look out for recurrences which can look like pimples, like red dots along the scar, because the recurrence is can be seen at the scar. Look out for palpable axillary lymph nodes, whether they are in the armpit, whether they are in the axilla. The other thing is to look out for lymph nodes in their neck. The supraclavicular lymph nodes are the easiest to feel them if there are recurrences. Also to ask them for any even symptoms of lethargy or backache, okay, because we're looking out for bone mets. Occasionally they think that the back pain is due to aging or osteoporosis. Also, patients on aromatase inhibitors, those who have ER positive breast cancers postmenopausal, they can get bone pain and joint aches. So sometimes we need to rule out other pathology that would help. You could contact the primary breast surgeon or the general surgeon or the oncologist. I will be happy to communicate with you if the patients will always have our contact numbers, you know, the clinic number, etc. Feel free to contact us. We welcome any communication because we are all in it together. We are all, as a community, we are helping to make sure that the patients get early treatment and early detection of recurrences if they do present to you earlier. Breast cancer patients actually are quite astute, you know. They do find out things that are wrong with them quite early on, and they need to be listened to, and not, you know, their problems shouldn't be swept under the carpet because that slight delay actually means a lot, because there's so many options of treatments these days. So do connect with us. We'll be happy to. You can even contact Dr. Saunthari in NCSM, who will direct you accordingly to the surgeons available in whichever state, you know. Yeah. So please, we are happy to help.
I think that's so important though, because one of the issues post-treatment is that during that treatment time, the person is seen so often and has so much input from the medical team. But once treatment is over, it's as if the net has fallen, you know, that there's no longer a net there to catch them. They feel so alone.
Yes.
And that navigation between the hospital and the treatment team and the community team, I think is incredibly important to support that patient throughout the journey, because the journey just doesn't stop there. You know, the journey continues.
It doesn't. And we need that connection, because and we need to tell them you can always come back. And I tell them, even if you see me once a year, it's fine, just see me once a year. I've had patients contacting me from my previous hospitals, you know, and I feel so overwhelmed that they remembered me. Then they and I've had relatives who during their sad times, when their relatives have passed on, they contact me and say, you know, by the way, mom passed away, etc. And I feel really overwhelmed that they remembered me. So we need to maintain that long-term relationship. I think there's a question here. One last question.
Yes, yes, that's your favorite. That would be your favorite question about fillers.
Yes. Okay. Young patients have had fillers and their heart lesions now. What tool would you suggest for investigations? Okay, it depends on the injection material of the fillers. Okay, so if they've had silicone, they would appear as blank. Ultrasound, you can't see anything but a black, a black screen. On mammogram, it appears as studded white features. You can't do early detection. If they've had hyaluronic acid, you see a little bit of the breast tissue, but overall, if they've had fillers, actually this prevents early detection of breast cancer. I've had patients, so have some of my colleagues in other hospitals, where the patients thought that those fillers were, they thought that the lumps were actually the fillers that they've had inserted injections before, but actually it was breast cancer and it was masked by these fillers. So unfortunately, these fillers, because it's already amalgamated with the breast tissue, you can't do anything about it. The only thing they can do is mastectomy. All right. Now, how are we going to investigate them? I send them for MRI of the breast every 1 to 2 years, especially more so if they have family history. So it's a tough job, but and also not everyone can tolerate MRI of the breast. But however, MRI of the breast is done in the prone position and is tolerated much better than MRIs of the spine, where you have to sit spine, and it's very claustrophobic, and some patients actually don't want to do it. But MRI of breast is in a much more comfortable. They are prone, and unfortunately, it takes 45 minutes of being still. So this is the only way we can try to detect whether any lumps are suspicious. Yeah, because from the MRI, contrasted MRI, not a plain MRIs, they need to have injection gadolinium for the radiologist to differentiate whether the masses are suspicious or not.
Okay. Thank you. I think we have gone through all the questions and perfectly on time. You see, Dr. Azlina, you said that, you don't think we can go for 2 hours. We've gone for 2 hours, and I think we can chat a lot more still.
Yes, you can.
Thank you so much for interesting and thought-provoking. I think, the challenges and the future that you mentioned later on of, whether or not there will be ever surgery again with breast cancer, whether we have the guts or the courage not to do surgery.
I hope not. I hope not, Saunthari. I'll be out of a job.
I don't think that day is going to come really soon, but yes.
Well, not with our current statistics, where half the women come in advanced breast cancers, unfortunately.
And I think that's one thing very good that you've mentioned that now to everybody in the audience today. I mean, Dr. Azlina has spoken about the advances there are in terms of early breast cancer. But we all have to realize that 48% of Malaysian women come at advanced breast cancer.
Yeah.
And we truly need to change that. And the role that all of you here, I see there's, 147 participants here today.
Wonderful.
Yes, but, your role truly is to get the women to come in earlier, so that, people like Azlina can actually do something which is going to, make a impact in terms of their recovery and their survival.
Yes.
So
everybody has a responsibility. Everybody has a sister, a mother, a friend. So it is very, very important. We need to get a hold on this, because for so many years I keep saying the same thing again and again and again and again, and I still see patients coming in with fungating breast cancer. It's really upsetting, really, really disappointing. And every time I see a fungating breast cancer, I cry inside, because we could have done so much. I mean, we have everything. You don't have to cross borders. You don't have to go across the causeway. We have everything here. But if the patients don't come, what can we do?
Yeah. Agreed. Agreed. So I think that would be your last statement, is that everyone, as you said, everyone has a role to play.
Yes.
So to all the participants here, you all have an active role. It's not a passive or reactive role to someone coming to you. You all have an active role in ensuring that breast literacy and breast education and awareness is definitely increased within the country. So with that, I thank Dr. Azlina for such an informative and excellent presentation. And I thank you from all of us here.
Thank you. Thank you for inviting me.
And we're so happy we got you, finally. So yes, so that is the end of today's SK Dharmalingam lecture series with Dr. Azlina Firzah. And to all of you who are still here, if you stay on, we will give you the PR code for your CME points. Yes. So thank you again, Dr. Azlina, and till the next time.
Thank you. Thank you.
Bye.
Bye-bye.
Bye, everyone.